thank you everyone else for joining us. We are going to have a live Q&A about functional medicine with pharmacist Michelle Moser. We're really excited to have her with us today and for her to answer all the questions that we have. So I will turn it over to you, Michelle.
Thank you so much for that lovely introduction. I'm very happy to be here, and I'm very happy to share information about low-dose naltrexone. So behind me, you'll actually see these 3 books. I am thrilled to be a clinical liaison with Revelation Pharma. We're associated with about 13, 14 pharmacies across the United States, and therefore I'm really happy to be able to share this information. I'm also a certified LDN Master through the Research Trust, and I'm a volunteer for the Research Trust as well. So today we're going to talk about some of those commonly asked questions about low-dose naltrexone. It is a medication that's very widely used for many, many, many different purposes. And a lot of times that's what throws off red flags for a lot of people. It's how in the world can a medication be great for cancer, good for autism, effective for Hashimoto thyroiditis, chronic pain, but also opiate withdrawal? I mean, how is it that something that also has to be compounded, how is that possible that it could be available for so many different conditions? And really, it's about the mechanism of action on how low-dose naltrexone works. So naltrexone as a whole was FDA approved back in 1964. So literally almost 60 years ago, this medication came on the market in a traditional dose of anywhere from 50 to 300 milligrams. And it was primarily designed to turn off morphine. So we were trying to make sure that morphine was safe and effective, but we really wanted to understand its mechanism of action. So in order to do that, we kind of needed something to kind of turn it off, an antagonist, something that would counteract its workings. So naltrexone was developed, and we know that naltrexone does hit those same pain receptors, mu, kappa, delta, that the pain medications hit, whether they're natural pain medications, naturally occurring substances like the morphine group, or the synthetics, oxycodone, hydrocodone, or even tramadol. So in some situations, low-dose naltrexone should not be used with those pain medications, because if it's used within 4 to 6 hours of those doses, if the doses are combined within that short amount of time, it's a very good possibility that the naltrexone will actually bind to that receptor, then the pain medication won't work. However, what we also know is that when we use naltrexone in little teeny weeny doses, microgram doses, we can actually help people get off of their opiates. So that is one fantastic opportunity. That was a study done back around probably 10 plus years ago. It was called the Oxytrex study, and I believe it was done by a major university. And it was actually little tiny, literally microgram dosing of naltrexone along with oxycodone. And what it showed is that it would block those pain receptors and help people to not need their opiates. And in some countries, even Norway, my gosh, this was again probably 10 plus years ago, Norway actually introduced it to a wide variety of their family practice docs, as well as their internal medicine providers, and said, look, we want to use this medication instead of pain medications because they too are seeing an opiate crisis. Low-dose naltrexone, in this case, ultra low-dose naltrexone, worked even better for pain control. It also had very few side effects, didn't have the constipation associated with it, doesn't have the habit-forming situation that a lot of the pain medications have as well. But you also didn't have as much like tummy upset and things like that. So we've known across the globe that naltrexone can be incredibly beneficial. Now, naltrexone works in other ways as well. So we know that naltrexone works to also help modulate the immune system. So it doesn't boost it, it doesn't minimize it, it actually modulates, which means to help it work more effectively. And then we also know that it will bind to very specific receptors to then change the way the body will react and whether or not it will produce different pro-inflammatory chemicals that actually induce inflammation. It can suppress those pathways. And we see that both internally and also on the skin. So today, that's just kind of a brief overview as to how naltrexone works. And what we have known over the last, probably 30 years now, is that naltrexone at microgram dosing, ultra low dose, works differently than very low dose up to 4.5 to 6 milligrams. And it works very differently than when we see it in higher doses. So it's a very interesting phenomenon. This medication has been studied and written up in more than 900 scientific papers, as well as a wide variety of case studies. And those are published in everything from the New England Journal of Medicine to the International Journal of Internal Medicine, a wide variety of autoimmune journals, as well as internal medicine, chronic pain, and various other dermatology articles and publications as well. So this is not a new medication. It is one that we see very effectively used, but it does need to be compounded, and this is why. So in the United States, it is commercially available in a 50 milligram tablet, naltrexone. Well, you can't really take that tablet and dissolve it in water and expect it to work. A couple different reasons. Number one, in the United States, when a commercially available product is manufactured, it's allowed to vary plus or minus 10%. So as you dilute that 10% plus or minus, and there's no way to know what batch is going to be 45 milligrams, 47.5, right on target at 50, 52, 53, 54, 55. I mean, we just don't know. But when you dilute that down and you're dealing with literally 100th or 1,000th or 1/10,000th of that dose, that 10% variability is a game changer. It literally will mean the difference between it working for someone and not working. So that's off the table. So we compound this in using active ingredient, and we compound this in tablets, in capsules, in sublingual solutions, suspensions, and troches. It could also be compounded in a transdermal gel, which means this medication can be delivered through the skin. And we primarily use that in populations that are very young, such as autistic children, or in populations that cannot swallow. We also have a topical formulation that literally will sit on the skin, but not delivered to the periphery. And we use that so that we can decrease the amount of itching associated with a dermatology issue, or to help minimize inflammation at that site, for example, like lichen sclerosis. But we never substitute a topical for an oral. We don't do that. We can use them simultaneously, but we always use oral or sublingual or transdermal. Transdermal has a delay of about 2.5 hours. So if we're applying the transdermal to the back of the hand or the inner wrist, this very vascular regions of the body, really easy to apply, very small. We can actually concentrate it, so it's a little tiny dose. From that, we won't see an onset of activity for about 2.5 hours. And that was published by Dr. McCandless back in the early 2000s. So we have scientific data on that. What we also have is scientific data that continues to be published, in literally probably 30 or 40 articles have been published over the last 4 years that deal with long COVID issues, because it's an inflammatory process. Also, how low-dose naltrexone works really well in cancers, how it can suppress tumor growth because of how we know it works on the opiate growth tumor receptor, which is how tumors grow. We have studied that in beta cell lymphomas. We've studied it in breast cancer. We've studied low-dose naltrexone in GI cancers. It's been phenomenal. And today, as of today, so this is June of 23, there are at least 2 clinical trials in progress to study the use of low-dose naltrexone in chronic regional pain syndrome, as well as another study that is in progress through a new drug application looking at low-dose naltrexone in the situation of Crohn's and ulcerative colitis. Two separate studies, but what I think is really exciting about that is that this medication is going to become more commonly known. Now, will that decrease our ability to compound low-dose naltrexone? I don't believe so. And this is why. Those studies are going to be very specific dosing parameters. And what we've learned over the last 10, 20 years of compounding low-dose naltrexone is that only about 50% of the people respond to a 4.5 milligram dose. That the other 50% actually respond at much lower doses. So for example, one of the questions that I hear about all the time is, how does low-dose naltrexone work in chronic pain? Well, not only does it work specifically on the pain receptors, but low-dose naltrexone, very low-dose naltrexone, ultra low-dose naltrexone can be used to identify pain and work through those same pain pathways through the interleukin processes, through the different chemokines and cytokines to work specifically on toll-like receptor 4, sometimes toll-like receptor 9, sometimes toll-like receptor, there's a couple other ones in between. And what we see is that less is more. So many times we're going to start somebody on 100 micrograms, 0.1 milligram. Well, then we slowly increase their dose, and we might actually give the medication to them twice a day, morning and night, or 3 times a day, morning, noon, and night, sometimes 4 times a day. But that's only for chronic pain situations like fibromyalgia, low back pain, chronic muscular issues. So we do have to identify where in the skeletal system those muscle fibers are reacting, which ones are inflamed, and then we can target that area. And again, we use this medication orally or in a sublingual form, because the sublingual form will be absorbed under the tongue and then delivered through the periphery. And that's what's really important. So there's very specific processes that we can see to identify pain and work on that. And because chronic pain is something that affects, I think I read a statistic recently that's like 44% of the population has a chronic pain issue, and it's one of the leading causes to days missed of work. And so I believe that if we can identify what really is going on, target those areas with maybe some magnesium, because we know that magnesium is a natural muscle relaxer. Magnesium plays really well with very low dose naltrexone. But then we can help people feel better sooner and without the addictive properties of like an oxycodone, a hydrocodone, or morphine, anything like that. Because the beauty of low-dose naltrexone, very low dose, ultra low dose, is that literally once you stop the medication, the benefits of the medication go away. They're gone. Zip, gone. You don't have to taper off, even though you will taper up your dose to find your happy dose. You literally don't have to taper off. You literally stop, but then the benefits of the medication are gone. So that's also another commonly asked question. It's like, am I going to be on this medication for the rest of my life? Well, it really depends on what you have going on. If you have an autoimmune disease, or 2 or 3 or 5, I mean, let's face it, most people are diagnosed with one, but perhaps there's other underlying issues. Some of them are genetically related. Some of them follow one side of the family tree or the other, like Hashimoto thyroiditis, for example. That tends to be more of a female side of the tree driven medication need, but we have to identify it first. It's also very interesting how we can look at belts around the globe and identify where we have low functioning thyroid issues more prevalent in women in certain latitudes than we do in other areas. Also with certain ethnicities. It's very interesting and fascinating to study this. But when we're using low-dose naltrexone for autoimmune, we tend to use this once a day dosing. We start low and we slowly increase the dose. Now, why do we start low? Well, most people are really sensitive to medications. They're what are self-described that they're hypersensitive to medications. Well, low-dose naltrexone, if you start low and slowly increase that dose over time, maybe 7 weeks, maybe 9 weeks, maybe a little bit longer, then we can hone in on what is best for that individual. Because the other question that we see a lot is, well, what's the best dose? There isn't one. I think that that's the biggest challenge for providers to really wrap their head around, is that this is a medication that has to be very finely tuned into that person's needs. What is really going on? Because rarely do we have just one issue. A lot of times we're going to see 3, 4, 5. They're not sleeping well. They have digestive issues. They have a lot of other things. And the reason is because as a whole body, we're going to see many faceted issues. The gut is definitely connected to the brain. The brain is definitely connected to other areas of the body. So does one control the other? Absolutely. But if we can individualize this medication, we're going to see better benefit quicker and for longer term, which means better successful patient outcomes. So we also have a Q&A session here. And if you have questions, please feel free to drop that in the Q&A, and I will monitor that as we go through and pick up those questions as needed. But in the meantime, I'm just going to continue on. So does low-dose naltrexone work right away? You know, that is a fantastic question. In some cases, yes. In some cases, no. And what's really kind of crazy is that the reason for that is it's got to work with the individual. If somebody has fibromyalgia, chronic fatigue, chronic pain, sleep disorder, it's going to take a little bit. But what is a little bit? Even with eczema, or what we also call atopic dermatitis, we could see results within 60 days, maybe 4 months, maybe 6 months. Now that sounds like a really long period of time, but this is my question to you. If you have these issues, how long have you had them? Years, decades, long, long time, right? And how many medications have you gone through? Have they been successful? Have they fallen short of your expectations? I mean, do they work a little bit, but not a lot? Well, that's what we hear a lot of times, is that patients who are interested in low-dose naltrexone literally say, you know, I've been dealing with this since I was a lot younger. And I mean, it's been 30, 40 years, and I just don't seem to get much relief. My doctors really don't know what to do with me. And it seems like I've tried every drug under the sun, and I just don't feel good. I just want to feel normal. And honestly, that tugs at every heartstring I have, is that when people just want to feel normal, really, that's all they want. I mean, that seems basic. That seems like quality of life is everything, right? We don't know how many days we have, so we got to make the best out of every one that we have. So truly, if we can find a medication that is low dose, low risk, low side effect, and doesn't cost a lot of money, why not give it a shot, right? I mean, honestly, why not give it a shot? There's a laundry list of disease states, chronic issues, medical concerns that low-dose naltrexone can be used with. If you're on antidepressants, if you're on anxiety medications, even if you're on biologics, yes, even if you're on biologics, we can use low-dose naltrexone. We got to be a little bit more careful, but we can use them. If you're on pain medications, muscle relaxants, a lot of people will find that over 1, 2, 3, 4, 6 months, they can actually reduce their doses of gabapentin, their muscle relaxants, even their pain medications, even their antidepressants, because they sleep better, they have more energy, and they just feel better all the way around. So there's another question in the chat. As for neuropathy, chronic pain, what do you think about topical medications with multiple actives in one cream? For example, combination of gabapentin, doxepin, lidocaine, and capsaicin. That's an excellent question. And I believe that a lot of times those work very well for that individual. But again, that topical is not a one size fits all. It's a great place to start, but it may not necessarily be where you end up. So we usually dispense about a 3 to, well, we don't usually go with a 3-month supply. We usually go with anywhere from a 4 to a 6-week supply on the topicals, because it is kind of a, and by the way, they're not really a topical, they're considered a transdermal, because topical will stay on the skin. And really what you want to do is you want to get it through the skin and into the blood supply so it can be kind of dispersed into a local area. So it's considered a systemic local product. And that's more of a transdermal. You got to get it through the water layers of the skin, through the stratum corneum into the dermal layers where the blood supply is. And then that blood supply, the capillaries, will actually take it around to the target issues. So that's really the difference between a topical and a transdermal. Sorry to get so technical, but I just want to make sure that we're clear. That transdermal product can be used in conjunction with low-dose naltrexone. Often low-dose naltrexone is a part of a multi-medication modality, and usually with time we can actually narrow that down. When someone comes into the office and they are hurting, and they're not sleeping well, they're having trouble working, they're grumpy, they're depressed, they're probably not working at their full capacity. You know, they're there for a reason. They've taken a lot of time away from family, away from work, out of their pocketbook to go to providers to get some relief. And so I love that the idea of a transdermal product can be offered. We can definitely use a shotgun effect, but don't forget about ultra low dose or very low dose naltrexone. So ultra low dose is just a few micrograms, like 1 to 10 micrograms. And we usually use that to get people off of their pain medications. Very low dose is 100 micrograms or 0.1 milligram. So 100 micrograms equals 0.1 milligram. And we usually use that for chronic pain situations. And we can do that in a sublingual drop. We can make capsules with that as well, or tablets. Or even troches that dissolve under the tongue. The liquids, in my professional opinion, are much easier to manipulate because you just vary how much you're actually drawing up in that syringe so that you can then vary your dose. And a lot of times with very low dosing chronic pain situations, we're probably going to add a second, third, maybe even a fourth dose during the day, which sounds kind of crazy. But when you talk with a wide variety of pain specialists, like Dr. Norman Marcus at the Norman Marcus Pain Center in New York, but also some of the other naturopath pain docs, as well as the oncology pain docs, you'll find that they're using very low dose naltrexone, and they're using it more than once or twice a day. And they're doing it because they're not concerned about the immune system. They're not concerned about having to block those endorphins and upregulate those. It still happens, but in a little bit different, a little bit less capacity. So that's an excellent question. It really helps lead toward, you know, again, low dose naltrexone, very low dose naltrexone doesn't cure anything. but it does help along those natural pathways that the body can trick itself into working much more efficiently. So another question that came in is, does LDN help with skin conditions? You know, it does. It absolutely. So again, we still use oral or sublingual product. And when I'm talking about skin conditions, atopic dermatitis like eczema. So there are some pictures of this woman who had this horrible eczema on the palmar surface of her hand, and the skin was literally peeling off. It was cracked, it was super dry, it was peeling, but she literally had to hold her hand in kind of a cupped or kind of a claw type formation, because if she spread her fingers or tried to arch her fingers back, it would crack and open up and it would ooze and bleed. It was really painful. Well, the problem is, I guess not the problem, but her career was that she typed a lot. So she was a professional executive receptionist, and she would type on a keyboard all day long. Well, when your fingers are moving like this, they've got to flex and open and stretch. And so it literally kept her from doing her job. And she had tried topical steroids, topical medications to help stop the overproduction of skin. She tried pretty much everything that was commercially available, even compounded medication. But when she started on low dose naltrexone, and in her situation, her dose was a 0.5 milligram. She took that at bedtime. She increased her dose every 7 days by 0.5, and she ended up, I believe, somewhere around 4.5 milligram. And within 60 days, she literally has before and after pictures. Within 60 days, her hands looked clear. They looked maybe a tiny bit dry, but the skin was all intact, and there wasn't any cracking on the surfaces where the fingers actually bend, and it was all cleared up. So she was able to go back to work, which was great because she was a single mom of 2 little kids. And so as the sole breadwinner, she needed to work. And she found that she stays on LDN and she doesn't have any issues, even when originally her atopic dermatitis, her eczema, was related to the varying temperatures of the seasons. And she lives in a state where the winters are very cold and the summers are rather warm and there's a lot of wind. So she definitely would have to be very careful about moisturizing. And she does. She makes sure that she uses a really good, very thick cream that have a lot of ceramides in it to make sure that the integrity of her skin is maintained very well. But we also use low dose naltrexone for issues like scleroderma and lichen sclerosis. So lichen sclerosis is one of those really, really tricky things. It sometimes happens in the mouth or the oral cavity, sometimes in the nose, sometimes in women in the labia. And it tends to be kind of an autoimmune disease where I'm not really sure if it's viral in nature, could be. Some biological dentists have led on that perhaps it's the presence of mercury or silver amalgams that actually triggers some of that. But we can use low dose naltrexone orally, sublingually, to help minimize that overproduction of cells, the inflammatory responses, as well as kind of the overproliferation that kind of roughly change in the skin. Now, this is where we can use it topically as well. And that would help because it's going to bind to the TLR9 receptor, which is on the outside of the cell. And that's going to help decrease the physical inflammation and also the itching, because TLR9 is associated with an itching process. So low dose naltrexone orally and topically can be used. And the topical is just as needed. And it's used for, sometimes about a month at a time, maybe less. And we would put that, if it's going to be used externally, we can use just a really nice kind of vanishing cream. If we are going to use it in the mouth or right on mucosal tissues, then we have muco-adhering bases that we can target, and that would allow the medication to stick to that tissue and stay there for a much longer period of time, which is great. So again, oral is always a number one, and then we can use topical subsequently as needed. Transdermal is usually reserved for those individuals who cannot swallow, for example, autistic children or individuals who have a hard time swallowing. Can LDN be taken with my depression medications, and do what medications interact with LDN? Really, really great question. So LDN really doesn't interact, so to speak. It can block pain medications, but that doesn't mean you can't take pain medications. It just means it has to be timed appropriately. So for example, if you're using low dose naltrexone at bedtime and you get up in the morning and you're hurting something awful, you can take your medication, your pain medication in the morning, because it's been more than 4 to 6 hours before or after that LDN dose. LDN plays really well with antidepressants, anti-anxiety medications. It's actually combined commercially with bupropion, which is a medication we use for depression. Brand names are Wellbutrin. We actually use bupropion to help stop smoking as well. But when we combine bupropion with naltrexone at a 4 to a 32 milligram dose, and that's usually split up throughout the day, it actually works to help us with weight loss. And what it does is it blocks our sensation of hunger. So bupropion does that a little bit. It also helps us to feel brighter and lighter and gives us a little more energy. But when we're using naltrexone in 4 to 32 milligrams, we're actually moving out of the low dose range into more of a typical range. And that combination product is commercially available, known as Contrave. So that is a prescription medication that a provider would have to write for. It is available in all across the United States. I'm sorry, I don't know if it's available in Canada or anywhere in Europe. I would assume so, or even Australia, but we've definitely compounded naltrexone by itself. So Contrave can be very expensive, and a lot of times it's not covered by insurance. And so we have actually seen where some people just don't tolerate the higher dose, the 8 milligram of naltrexone right off the bat. So we will compound smaller doses, and then people will work up. And so they'll start with their typical dose of bupropion, 75 milligrams or so, maybe even higher, and then add in naltrexone and then slowly increase that dose. Most people, even if they're using this for weight loss, show that they have more energy. They feel lighter when they wake up in the morning. They have less depression. They have less anxiety. And in previous low dose or the LDN Research Trust conferences, I'm thinking back to 2017 and 2019, they were actually held in Portland, and both Dr. Forster and who is the other psychiatrist? Anyway, there were two physicians that spoke on the use of low dose naltrexone in depression, in PTSD, in a wide variety of mental health applications, and they were using low doses, but sometimes multiple times during the day, because again, with depression, we do see pain associated with that. And anytime we have chronic pain, we usually have depression as well. But a lot of times there tends to be a traumatic issue. And when we can use a medication to target just those areas, we see better outcomes, much more successful outcomes. It does take a little bit of time. I would ask that somebody give us at least 2 months, if not closer to 4 to 6. But again, when you're dealing with a medication or a journey that you've been on and you haven't seen relief from a wide variety of medications, because a lot of antidepressant medications actually lower your libido, lower your ability to have an orgasm, lower your ability to connect with people. And that's opposite of what we define as a happy life. But the other part of it too is that we want to engage with people. We want to connect with people. We want to have those relationships. And whether we're dealing with PTSD or depression or anxiety, all of those medications, SSRIs, SNRIs, even some of the antipsychotic medications, they all play very well with low-dose naltrexone. We do see a lot of people actually starting to decrease their antidepressant doses, anxiety medications, psychiatric medications as they find their happy dose with naltrexone. Most people will increase their dose by 0.5 milligram thereabouts, unless there's a chronic pain, and then we start much lower at 0.1. And they will increase their dose about every 7 days or so until we get up. If we're using very low doses, we might end up at like between 1.5 and 2 milligrams total daily dose. Whereas if we're using low doses, we might end up with a smaller dose in the morning, or I should say a little dose in one end of the day and a larger dose at another end of the day. Total daily dose meaning someplace between 3 and 6 milligrams. Again, we have to identify the individual in front of us and what is going to be best for them. And that can be rather arduous for a lot of providers to even think about, oh my gosh, how many times am I going to see this patient? Is the patient going to actually come back? And this is where working with a compounding pharmacy, especially one that is really in tune with LDN and their patients, can be incredibly beneficial for the provider as well, is because we have electronic platforms. Providers do too, but there's electronic platforms out there, for example, Outcome MD, where we can actually send a survey out to a patient when the medication is initially prescribed. And we send them kind of an FDA approved list of questions. And the patient will log into the link on their phone and be able to answer that set of questions. And then the platform will give them kind of a dial reading as to where they're at. And then they can answer that same set of questions maybe 4 weeks later, and they can actually see their improvement. Maybe 2 or 3 or 4 months later, and again, see their improvement. And that's an amazing visual for the patient to show that the provider is the hero here. The provider knew enough to say, we need to dial in your dose specifically for you because of what you've got going on. Historically, we know this medication has worked in many, many, many different situations. And this is a medication that will work with everything else that you've got going on. So the patient does the work, so to speak, by answering the questions. That information either comes back to the provider or to the pharmacist and can very easily be shared with the provider or the pharmacist. So it can actually cross over. And that information is so extraordinarily helpful because it gives us instant feedback as to what do we need to do to help this patient find their happy dose. Maybe after 4 weeks, they've decided that the vivid dreams were too much to handle. I'm out. I'm done. I'm not doing this anymore. And they quit their low-dose naltrexone. Well, the provider isn't necessarily going to know that. And the pharmacist may not necessarily know that either. But this platform will allow us to identify that, have better communication with the patient, be able to maybe lower their dose, because a lot of times less is more with naltrexone, lower that dose, and then maybe even more slightly increase that. We do that all the time. That is something that it's just not uncommon to have 9 to a dozen dose changes in a 2-month time frame. Well, a provider and their staff doesn't have time to chase that, whereas the pharmacists have tools by which we can help take care of that process. And it works so much better than just like, here's your pills, we'll talk soon. So another question is that my doctor doesn't really know much about low-dose naltrexone. How can they learn about it? Because you really want to try it. Well, that's fabulous. I totally agree. And it's kind of interesting that the information about low-dose naltrexone has to come from a compounding pharmacist, right? So why isn't that it's just not out there? Why don't more people know about it? Well, because it's not commercially available. You don't see commercials about it on TV while you're watching Jeopardy at night, right? So the information has to be provided, literally sent electronically or handed to them. But are they going to take the time to read it? Well, we can summarize the first 900 articles on low-dose naltrexone in one paper. I call it the Dartmouth paper. It was literally published by professors at Dartmouth University. So there was a physician there who literally was like, oh my gosh, there's so much information here. We need to compile this. So he broke it down into categories by disease state. And then through the summary of those articles, listed the articles and said, okay, with this disease state, this is what the study was. This is the mechanism of action. This is the dosing parameters. And this is what the patient population looked like. And this was the outcome. It's awesome. So that was published back in 2017 or 18. And we've had many other articles written since then, long COVID, more on cancer treatment, more on chronic pain. I mean, there's just been a ton, right? So with that, we can provide even more information. And as a compounding pharmacist, as a clinical liaison, as an LDN Master Specialist, I am more than happy that if you email me, I will get you the information that you need. If you want me to contact your provider and have a Zoom meeting with them or have a sit down with them, if I'm in the area, I will more than happy to do that. Usually we can reach out virtually and get more done, quite honestly. Electronically, I can send any document you need. I can send dosing parameters. I can send dosing schedules. I can send clinical data and a wide variety of research to back up your disease state. There's literally well over 100 disease states that have been studied with low-dose naltrexone, which is super duper cool. There have also been, so these are my favorite 3 books. So the LDN book, volume 1, and sorry, volume 2 and volume 3. So volume 3 was published November of 22. Now, even though there's 3 books, the chapters don't repeat except for the very first chapter, which discusses the mechanism of action. But otherwise, these books will address everything from ulcerative colitis to depression and anxiety to cancer treatments to the use of LDN and cannabidiols, the use of LDN in infertility, autoimmune diseases such as thyroid issues or skin conditions, all of those things. So these are only the first 3 books, but they're a wealth of information and they're really easy to read. What's also really awesome is that at the end of every chapter, and maybe it's actually just in the appendix in the very back, but the back 25% of the book is all research information. So it's all the clinical data to actually back up what was stated. And these books are not a LDN sales pitch. This is clinical data that supports disease state and the use of a compounded medication for successful patient outcomes, which I think is what we're all looking to do, right? We're here to help patients feel better sooner, quicker, get them back to their lives, get them back to their loved ones, get them back to their workforce if that's what they choose to do, but certainly allow them to feel normal. I mean, isn't that just a bare minimum? My gosh. Wow. You can also go to the LDN Research Trust.org and you can view the previous conferences. There is another conference coming up in third week of June, so just in a couple weeks. It's back in Carbondale, Pennsylvania. If you choose to show up, you need to register. So again, go out to ldnresearchtrust.org and you can click on the events tab and you can sign up there. If you want a book sent to you, email me, call me at Makers Compounding Pharmacy. You're welcome to To do that, my phone number here at the store is 360-757-6677. So again, that's 360-757-6677. Or you can email me. I'm happy to answer all your questions. Or if you want a book mailed to you, let me know. My email is mmoser, so MMOSER at revcustomrx.com, REVCUSTOMRX.com. Another question, what time of day should I take LDN? Do I have to take it at bedtime? And do you need to take the medication on a full stomach? Again, awesome questions. So I will say traditionally we start with bedtime dosing. And the reason is because the body's quieter. LDN can actually get in there and do its work. The science has shown us that when we take LDN at bedtime, we actually see an upregulation of endorphins, so our natural pain killers, and modulation of the immune system for the next 18 hours. That does happen if you take it in the morning as well. So most people will move to a morning dose if they have vivid dreams that it's just really bothering them and it's just disrupting their sleep. People with PTSD and depression, anxiety, a lot of times will take it in the morning. But if you get drowsy from that, then maybe take it at dinner time and see if that is helpful. So it really can be taken pretty much any time of day. It's still going to work just as well. But what we do see when we take it at bedtime is many people report that they have better sleep in time. So usually the vivid dreams go away in about a week or so. You do not have to take it on a full stomach. Water is just fine. Some people complain of a little bit of stomach upset, and that's again how the medication is actually helping to heal the gut. It can change the biome for the good. It can also bind to different receptors. We actually have opiate receptors in our gut, and LDN can bind to that. So if you are prone to constipation, we need to be careful of that. Please let your compounding pharmacist know so that they can be advised of that. And a lot of times what we do is we use a liquid instead of a capsule or a tablet. The liquids that we use are usually in an oil base, either almond oil, olive oil, or MCT oil. So if you have an allergy to nuts, please let your compounding pharmacist know. The reason why we use oils, and then it becomes a suspension, so you got to shake it up super good before every single dose. And the reason why we use oils is because they have a better shelf life. So they're going to be shelf stable for at least 90 days. Whereas if there's a water-based medium, we can only give it a 30 or 35-day shelf life. Those are the guidelines that are put together by the USP and the FDA. And as a compounding pharmacist, that's what we have to adhere to. So we want to make sure that patients understand that their medications are effective, but also are shelf stable. So that's what we have to go with. Capsules and tablets are 180-day or 6-month beyond use date. Troches, which dissolve underneath the tongue, are usually going to be a 90-day to 180-day. But oral suspensions usually are anywhere from a 30 to a 90-day beyond use dating. So that's going to help. Now the liquids, because LDN is bitter, naltrexone is a bitter molecule, we tend to throw a splash of stevia, so a natural sweetener, and then we can throw some flavors in there too. So right now, Makers is compounding berry cobbler, which is actually really good. It's like this purple berry flavor with a touch of cinnamon, and I mean, my gosh, it tastes like a cobbler. And we've perfected things like tangerine cream, cinnamon cream, lemon lime, mint. So you notice that those are kind of oils. There's a lot of natural oils in that. We also have a mango passion fruit, and there's a few others as well that can be flavored with that, so that you don't have this horrible kind of oily, bitter mess in your mouth. we want to make sure that it's palatable and that you have a good experience with it as well. I mean, that's really important. People are not going to take it if, if it doesn't taste great, if it tastes bitter and yucky. But capsules usually don't have a flavor. Tablets don't have a flavor. Troches and sublingual drops can have a flavor. And of course, we don't do anything with the transdermals. They just push through the skin. So that works there. So Tara, do we have any other questions that have come through the chat?
Yes, it looks like we got one more. So
Okay.
pull that up.
Oh, this is really great because this is an area I haven't touched on yet. So can LDN be useful in Lyme disease or other infection? So let's define infection first, okay? So Lyme disease can be virus in nature, can also be other vectors that are protozoa, parasites, but also like staph and strep and a wide variety of other infections. And yes, low dose naltrexone and very low dose naltrexone, so 0.1 up to 4 milligram, 4.5 milligram, can be used. And what we see is that it not only decreases the inflammation associated with that, but it actually has properties by which it can get into the reproductive cycle and help reduce that. But it will also reduce the pro-inflammatory cytokines or pro-inflammatory chemicals that are produced in the body whenever we're trying to ward off or attack a virus, protozoa, some type of vector. So a vector is an invader, right? So whether it's a staph infection, strep infection, fungus, yeast, any of those. So this leads to like psoriatic arthritis. So that's usually fungus or a yeast in nature, usually harbors in the gut. And then we see a systemic rash. So these plaque areas. So this will tie into the dermatology area that we started talking about, but also lead into these chronic illnesses that are very difficult to identify, but also to treat. Now, I will warn that when we start low-dose naltrexone, it's not uncommon to have a bloom. So Dr. Sherman out of Arizona actually addressed this issue at the LDN conference in 21. And what she talked about is that as low-dose naltrexone decreases, or very low-dose naltrexone decreases the inflammation, it kind of allows the virus or the fungus or the vector to kind of come to the surface and bloom. So if you can imagine, all of the little seeds on a dandelion that the wind will then carry those seeds off into the periphery. Well, that happens with viruses too. And so sometimes you're going to feel worse before you feel better. We always want to caution people about that. So please stay with your medication. This will help. But we need to ramp up other medications to help minimize those symptoms. So whether we're using topical products to help decrease the irritation, the itching, the redness, the rash, or help also use antifungals or other anti-infectives to help decrease that infection. So sometimes we use doxycycline, sometimes we use nystatin. I mean, there's a wide variety of things, even ivermectin, that we can use. So we just need to be aware of those. Low-dose naltrexone, very low-dose naltrexone, again, plays very well with all of the anti-infectives, all of the antivirals, as well as the anti-yeast, antifungal medications. So there's no drug interactions there. We don't have to change how the medication is used, whether it's your antibiotic, your anti-infective, or the LDN. We don't have to, be careful of 3 or 4 hours. But we do have to be careful if you're on thyroid medication. Again, that should be taken in the morning all by itself with just water. Wait an hour or two before you eat and drink coffee or take any other medications. Now, the next question that came into the chat was about fillers. And I think this is a fantastic topic to kind of wrap up this hour Q&A session. So fillers are very important, super important. And why is that? Well, people have allergies. They have lactose intolerance. They have gluten intolerance. They maybe have a true allergy to a wide variety of ingredients. Compounding pharmacists can tailor the filler that is used, and we always have to use some kind of filler. It doesn't matter if it's a filler in a capsule or a filler in a tablet. We have to be able to fill it up. There's just, we can't just take a capsule and measure out 0.1 milligram. That is not possible. It's just not. We don't have measuring devices that will allow us to do that. So we have to use some kind of filler. But when we're dealing with autoimmune disease, when we're talking about individuals who are ultra sensitive to medications, to things floating around in the air, they have allergies to seasonal issues, but they also have food intolerances or food allergies, then that's where we can compound and get the filler right. Now, that doesn't mean you can't change it. You absolutely can change it, especially when we're dealing with liquids. So if you're allergic to nuts, obviously we're not going to use almond oil. We'll have to use olive oil or MCT oil. But some people that are allergic to nuts are also allergic to coconut. So we got to be careful there. So then olive oil is the option. We do have other oils as well, but we're not going to use a food grade product. We're going to use a professional grade that has, it's an NF grade, a national formulary grade base. And we do have some water bases that we can use. Of course, it's going to have a shorter beyond use date, but we'll do everything we possibly can for that. Sometimes the fillers that we use in capsules or tablets cause people to have gastric upset. So we want to make sure that that isn't just a short-term issue. If it does become a long-term issue, let's switch that out and maybe even change dosage forms, whatever's going to work out best. So again, when we're tailoring these medications specifically to the individual, we have to have in-depth conversations with our patients to ensure they understand why they're taking the medication, how we can best prepare that medication for them, for that specific individual, manipulate that dose so that we can find the best successful outcomes, and then help them on their health journey so that they're not just healthy today, but they have the health and wellness that they're seeking so that they can live out their days to their best potential. And that is why I'm an LDN Master Specialist. That is why I love this drug. I've been a pharmacist for 36 years. And honestly, this is the most exciting molecule I've ever come across. It is so well studied. It has so much great scientific data behind it, so much a fantastic case study, and it's only going to get better. So I thank you very, very much for all of your questions today. It's been just fantastic. I hope that this has been beneficial. If you'd like to reach out to me, again, my email is mmoser@revcustomrx.com, MMOSER@REVCUSTOMRX.com. That's the best way to get a hold of me. You can also reach me at Makers Compounding Pharmacy, 360-757-6677. If I'm not here for whatever reason, leave a message and we will get back to you as quickly as we can. Tara, I want to thank you very much for hosting this today and for all the participants and all the fantastic questions. This has been just a fantastic hour. I've really enjoyed myself, and I hope you all have come away with a little bit better understanding about low-dose naltrexone and its applications. So thanks very, very much for being here, and we'll see you next time.
Thank you, Michelle. Thank you, everyone.